Assalamu alaikum everyone. Let's start today. Hope everybody is well. सब लोग ठीक ठाक हैं, घर में सब लोग खैर खैरियत से हैं और इस चीज़ की दुआ करें कि जल्द अज जल्द ये कोरोना जो है ना ये हमारी ज़िंदगियों से ख़त्म तो नहीं होगा. इट्स हेयर टू स्टे, बट ये है कि वी गेट यूज्ड टू बिकमिंग मतलब हम वो सब चीज़ें जो हमारी सेफ्टी के लिए वो हम करने की इतनी आदत हो जाए कि हम उनके साथ भी बाहर निकल सकें. मीनिंग मास्क एंड हैंड सैनिटाइजर्स, ग्लव्स. आई डोंट रियली अग्री विद ग्लव्स, इसलिए कि ग्लव्स पहन के हम बहुत ज़्यादा एक फॉल्स सेंस ऑफ सिक्योरिटी के अंदर आ जाते हैं और फिर ग्लव्स के साथ हम हर चीज़ को टच करते हैं और उसमें वी आर लायबल टू ट्रांसफर द इन्फेक्शन फ्रॉम वन प्लेस टू अनदर. और अपने ऊपर भी हम फिर मास्क को भी टच करते हैं अपने और जगहों, मतलब हाथों से हम बहुत सारे अपने फ़ोन्स को, बैग्स को, हर चीज़ को हम टच करते हैं. सो social distancing and the mask, these are the two things जो कि मैं कहती हूँ कि ज़रूरी हैं and we need to establish them as a normal practice in our life, and then we will go back to our normal routines. Inshallah, hopefully soon this is going to pass with everybody's दुआएं और सबकी जो हम लोग कोशिशों में लगे हुए कि अल्लाह मियाँ हमारी सबकी सुन ले और we come back to the normal stage. So today we are going to start with another important virus, and that is the HIV virus. Okay, HIV is again a very important SCQ question और MCQ question as well. So दोनों aspects से इसके अंदर से आपके पास questions आते हैं. It's a long chapter, बट अगर आप इस चैप्टर को प्रॉपरली पढ़ोगे तो इसका जो मटेरियल है और इसके अंदर जो कंटेंट है दैट इज़ नॉट गोइंग टू बी टू एक्सटेंसिव इफ़ यू आर गोइंग टू रीड इट प्रॉपरली. इसकी एक प्रॉपर रीडिंग दो और अंडरलाइन करो थिंग्स विच आर इम्पॉर्टेंट एंड लीव आउट द थिंग्स विच आर नॉट इम्पॉर्टेंट. तो आप देखोगे कि चैप्टर जो है ऑटोमेटिकली 50% में रिड्यूस हो जाएगा. ट्रीटमेंट का जो पोर्शन है आई एम नॉट गोइंग टू डिस्कस इट बिकॉज ट्रीटमेंट आप फार्माकोलॉजी में पढ़ते हो और ट्रीटमेंट का क्वेश्चन जो है एज सच हमारे पैथोलॉजी में नहीं आता. ऑल्दो वैक्सीनेशन जहाँ जहाँ है वो वैक्सीन का पोर्शन ज़रूर आता है इन आवर क्वेश्चंस. ठीक है, सो आपको ट्रीटमेंट एज पर से नहीं पूछते बट आपको वैक्सीनेशन विच इज़ अनदर फॉर्म ऑफ ट्रीटमेंट वो ज़रूर पूछते हैं. सो एनी बैक्टीरिया, एनी वायरस, एनी ऑर्गेनिज्म which has a vaccine, you need to know the vaccine and the prevention of that disease. So let's start with HIV. HIV stands for Human Immunodeficiency Virus, and it is a causative agent of a disease which is referred to as AIDS or Acquired Immunodeficiency Syndrome. So what is HIV or AIDS? HIV or AIDS, HIV is the virus, AIDS is the disease, and so HIV is the cause of AIDS. And it was first identified in 1981 in a small group of homosexual men who presented with unusual opportunistic infections. And it was seen in these people when they were investigated, they were found to be carrying a viral infection, and which was later identified as the HIV or the Human Immunodeficiency Virus. And the disease which was produced in these individuals was referred to as the Acquired Immunodeficiency Syndrome, which affects the body's immune system, resulting in an infection which progresses over a period of many months or years, and it results in a group of symptoms that characterize this syndrome. So what are the actual signs and symptoms? We'll discuss them in a few minutes. So the pathogen, as I've told you, is the HIV or the Human Immunodeficiency Virus, and it is also known as the human T-cell lymphotropic retrovirus. Why the retrovirus? Because it belongs to the family of retroviruses. The genus is lentivirus, the family is the retrovirus. And lymphotropic, T-cell lymphotropic, because it has an affinity for the T cells. or it loves the T cells, human T cells. So, and the disease is found in various vertebrates, and it is associated with a variety of diseases in both animals and humans. They have these retroviruses, they have been associated with malignancies, autoimmune disorders, immunodeficiency syndromes, anemias, bone joints diseases, and diseases of the central nervous system. So, as a group, they are associated with a lot of infections and a lot of malignancies. HIV is of two types, HIV-1 and HIV-2. HIV-1 is found all over the world, whereas HIV-2 has been found to be completely located in the West Africa. It is not found in the rest of the areas. Then in your book, it is all mentioned that there are certain clades. Clades means that they are subgroups of the HIV virus which are particularly present in certain areas of the world. I won't go into the details because basically what you need to remember is HIV-1 and HIV-2 and where they are prevalent. Coming to the structure of the HIV virus, we have the virus which is going to be a So we have the HIV virus, and HIV virus is a spherical virus, and it is 90 to 120 nanometers in diameter. Again, it's an enveloped virus, and this envelope is of bilayer, and this is derived from the host cell membrane. And within this envelope, you have these structures, glycoproteins which are embedded, and these glycoproteins constitute the major spikes on the surface of this envelope, and this spike has two components. Number one is the knob, and number two is the transmembrane portion which goes inside this lipid bilayer. The glycoproteins, they are viral coded, and they are going to be synthesized by the virus when it takes over the machinery of the cell, of the host cell. So we have this knob which is made up of two components, a knob which is the docking glycoprotein, or the glycoprotein by means of which it gets attached to the cell surface or to the receptors which are present on the host cells, and this is a glycoprotein which is referred to as GP120. Then we have the GP41, which is the transmembrane glycoprotein, and it spans the two layers of the lipid envelope. Then we have the matrix protein, which is the protein 17, which has been labeled as the protein 17. Then we have the then we have the capsid, which is bullet shaped, and within the capsid we have the RNA genome, and we have the various enzymes like the integrase and the reverse transcriptase. This is a diploid RNA genome. Diploid means that there are two copies, but it does not mean that the copy is one is the positive and one is the negative. Both of them are identical copies. So the HIV structure is made up of an envelope, as we've discussed, in with glycoprotein 120 and 41, and then we have the matrix protein 17. Then we have the capsid, which is bullet shaped, and this is made up of protein 24, capsid protein 24. Then we have the nucleocapsid protein, which is the protein 7, and this is present over the RNA genome. Then we have the enzymes, which include the integrase, protease, and the reverse transcriptase. Integrase, protease, and the protease, reverse transcriptase, and the integrase. The HIV genome has three structural proteins, three structural genes. Number one is the GAG gene, the pole gene, and the envelope gene. The GAG gene is going to code for the P17, P24, P7, and P6 genes, whereas the pole is going to code for the P51 and the P31 and the P15, whereas the envelope is going to code for the G120 and GP41. Let's go back. GP41 and GP120, that is going to be coded by the envelope genes. Then we have the nucleocapsid proteins P17 and the matrix P7, P17, and they are going to be coded when P24, they are going to be coded by the a GAG gene, and all of these they are the capsid, nucleocapsid, and the matrix proteins. And then we have the enzymes, which are going to be coded by this by the pole gene. So these are the three structural genes which are present. Apart from that, there are certain non-structural or accessory genes which are also going to be present. So GAG, pole and the envelope gene, and then we have the essential regulatory elements which are the TAT and the REV genes, and then we have the accessory proteins which are the NEF, VPR, VIF, and the VPU. What are the roles of these and what are the functions of these? We've discussed the structural genes, that is the GAG, pole, and the envelope, that they are responsible for the production of various proteins. Then we have the TAT gene, and the TAT gene is also known as the HIV transactivator. It plays an important role in regulating the reverse transcriptase enzyme, and this therefore it is responsible for the efficient synthesis of the viral messenger RNA and the release of the virions from the infected cells. So it has two roles. Number one, synthesis of viral messenger RNA, because it is going to regulate the reverse transcriptase enzyme, which is going to convert the messenger RNA into the DNA. And once the DNA is produced, then it is going to produce the RNA copies, and which are going to be responsible for synthesis of various proteins in the cell. And then it is also responsible for the release of the virions from the infected cells. Second is the REV gene, which is a regulator of the expression of the virion proteins. This is important for the synthesis of the viral proteins, and therefore an important component of the viral replication process. So the TAT gene is going to control the reverse transcriptase enzyme and the synthesis of the messenger RNA, and then the regulator gene, REV gene, is going to control the synthesis of the major viral proteins. And once both of these have been produced, they are going to be assembled into the virion, and this virion is then again going to be released from the infected cells through the activity of the TAT gene. And these are the essential regulatory elements without which the virus is not going to be able to multiply or produce its progeny. Then there are certain accessory genes, regulatory genes, which are going to be important in playing certain roles, like the VPR or the lentivirus protein R, and this plays an important role in replication of the virus. Then we have the VIF or the viral infectivity. This is important for the infectivity of HIV-1 virions depending upon the cell type. And if a VIF1 is present, it is going to be important for the synthesis of infectious viruses in the lymphocytes and the macrophages. So the presence of VIF is required by the HIV to synthesize infectious viruses within the lymphocytes and the macrophages. If the VIF level is going to be low or it is going to be absent, then the lymphocytes and macrophages will go into a latent stage, or rather the HIV is going to go into a latent stage, and it is going to just stop there. It is not going to multiply, and it is just going to remain within the lymphocytes and the macrophages. And that is why there are periods of latency or periods of quiet in a person who is suffering from HIV. This HIV is within the cells, but it is not multiplying, so it is not producing any signs and symptoms, and the individual does not know he is suffering from HIV or not. Then we have the NEF or the negative factor gene, and this is involved in multiple functions of the replicative cycle, and it plays an important role in cell apoptosis, and it also plays an important role in Cd4 downregulation, and because it is going to prevent the MHC1 class molecules from presenting the antigen on their surface. So if any F is present, it is going to downregulate both MHC class 1 as well as the CD4 cells, and therefore they will not be able to destroy the virus, and this is therefore responsible for increased virus infectivity. Then we have the virus protein U, which is specific to again HIV-1, and it is also involved in CD4 degradation as well as the release of virions from the infected cells. Then the important enzymes are the factors of virulence for this organism. Number one is the reverse transcriptase. So as we've discussed, reverse transcriptase is present in other retroviruses as well, and it generates a complementary DNA or a DNA copy of the RNA template. Once the RNA template is produced, once the DNA template is produced, a DNA copy is produced from the RNA template. HIV is an RNA virus, so that RNA has to be converted into a DNA copy. Only then it can be undergo the further replication cycle. So we have the reverse transcriptase enzyme, which is going to copy the RNA and produce a complementary DNA. This DNA then becomes the master copy, and this is then going to synthesize the various messenger RNA, and this is then going to synthesize the various proteins. And for once the proteins are going to be produced, the enzyme protease comes into action, and it is going to cleave the newly synthesized polyproteins at the appropriate places to create the mature protein components of the HIV virion. Without HIV protease, the HIV virions will remain uninfectious. So there will be long strands of proteins which are going to be produced, and this protease is going to splice them and take out the portions which are going to be essential components of the HIV particle. And if protease does not work, then the HIV virions do not they do not work. Then we have the ribonuclease, which catalyzes the cleavage of the RNA, and then we have the integrase enzyme, which is responsible for the insertion of the viral DNA into the host chromosomal DNA, after which the whole process of replication starts. Now, what are the routes of transmission? There are different routes of transmission of the HIV virus, and they have different percentages of infectivity. But the most common, which is responsible for 80% of the infections worldwide, is the sexual route. Unprotected sex is the main cause of HIV or AIDS transmission from one individual to the other. There are certain modifying factors, like if there is a low viral load is less than 400 copies, transmission is going to be less likely. If there is circumcision, then there is a reduced risk of infection for the circumcised men. If there is a co-infection, for example, there's an genital inflammation, there is a genital mucosal damage, all of these factors, they will expose the mucosa, they will abrade the mucosa, they will make the mucosa they will breach the mucosa. The intactness of the mucosa will be lost, and therefore these organisms can readily pass through that breached mucosa or through that torn mucosa into the system and produce the disease. HIV, so it can be transmitted through the unprotected sex, which is the major route of transmission, but drug addicts, blood transfusion, pregnancy, and non-sterile instruments are other vehicles of transmission of HIV or AIDS from one person to another. It is not transmitted through food, through handshakes, through insect bites, through water in the pool, through a kiss. These are not, because saliva is a very it is, in different studies it has been said that saliva does contain HIV, but probably the amount of HIV in the saliva is so few that it does not become an important route of transmission of the HIV virus. A very important transmission route apart from the sexual is the parenteral. Parenteral is the, after the sexual transmission, it is the major route of transmission of the HIV from one individual to the other. And it can be caused through needle sharing. One person uses a needle for drug intake, and the same needle is being utilized by different drug addicts for giving themselves the boost, giving themselves the dose. And even if one individual is HIV positive, then this can be a vehicle of transmission of HIV from one person to another. Needle stick injuries, as can occur in the hospital settings, in the lab settings, and healthcare workers are exposed to such injuries. In those situations, you do not know the individual or the person who is giving you a blood sample whether he is HIV positive or not. So this can be another source. Then we have infectious blood. Lab personnel or healthcare workers who are dealing with patients and there is spillage of their, for example, a healthcare worker has taken the sample of an individual who is HIV positive, that gets spilled on the way, and it gets splattered on the hands. And if there is even a minor cut on the hands of that individual, and or if he is not wearing gloves and the skin is exposed and there are minor cuts, then that blood can be a source of infection. Or if that blood gets on the mucous membranes, if that blood gets attached to the mucous membrane of the of the individual, then that can also be a source of infection. For example, you have touched the blood, you do not know whether the sample has dried on your hands or not, you are not wearing gloves, you're not taking precautions, you touch your face, you touch your lips, or you touch your nose. These are the mucous membranes which can be exposed to the virus by these means. Then a most important transfer route is the blood transfusions. Nowadays the risk has been reduced drastically because of the screening of the blood for HIV and other HIV, HCV, HBV, etc. But previously, when blood transfusions were not screened for HIV, then there was a huge risk of transmission of HIV from one individual to the other. Then we have the vertical transmission, that is the perinatal transmission from the mother to the child. And this transmission can occur from an HIV positive mother during pregnancy. The virus can pass from the mother to the infant within the womb, or it can occur during the labor and delivery when there is sharing of the opening of the blood channels, and there is the transfer of blood to the child, and then it can also occur through the breastfeeding. The risk of transmission can be lowered if the HIV infection is treated and the viral load is below the limit of detection. Coming to the replication cycle, this replication cycle also becomes a part of pathogenesis of the organism. So if you are asked about the pathogenesis of HIV, you are going to describe the replication cycle briefly in that pathogenesis as well. So we have the HIV virion, and this is going to now bind to the T cells, monocytes, macrophages, any other dendritic cells, any of the cells which have a CD4 and a chemokine receptor. So these two receptors, they are required for the attachment of the HIV virus to a cell membrane. So once the attachment of the CD4 and the chemokine receptor occurs through the GP120, the virus gets attached to the plasma membrane of the cell. Once this takes place, there is the fusion of the HIV membrane with the cell membrane, release, destruction of this cell envelope, and the release of the viral genome into the cytoplasm. Once the HIV RNA genome is released into the cytoplasm of the cell, the reverse transcriptase, which is present, which is an enzyme of the HIV, that is going to become activated, and it is going to produce a copy of the RNA genome, and this is known as the proviral DNA. Now this proviral DNA can go into the nucleus of the cell. The HIV RNA genome cannot directly go into the nucleus of the cell. It has to be converted into a DNA, and this DNA will pass into the nucleus of the cell. Once it is in the nucleus, then the second enzyme, which is the integrase enzyme, that is going to cause the integration of this viral DNA into the cellular DNA. So once this HIV DNA, proviral DNA of the proviral RNA, proviral DNA of the HIV gets integrated into the HIV DNA of the the HIV DNA gets integrated into the cellular DNA, you have this HIV DNA taking over the mechanism of replication of the cell, and instead of the cellular components being synthesized, now it is going to start synthesizing the HIV components. So you have the messenger RNA and then the formation of the various HIV proteins, and these proteins are then going to be passed out into the cytoplasm of the cell. Once they are within the cytoplasm of the cell, there is the assembly of the various structures resulting in the formation of the HIV core structure. That is the HIV proteins, the HIV RNA around with the nucleocapsid that gets assembled, and then it goes up to the plasma membrane of the cell, where it is going to express the HGP120 and GP41, and it is going to acquire the lipid envelope from the plasma membrane of the cell, and then it is going to bud out from this cell, resulting in the formation of a new HIV virion. And in this way, several new viral particles are going to be synthesized. Because of the activation of the cell, cytokine is going to be released, and this is going to help in the transcription of the HIV genome, HIV DNA conversion into HIV RNA, then the transport of the RNA into the cytoplasm, and the synthesis of various proteins. So this results in the synthesis of a large number of HIV particles. If this process is slow and it is occurring at a medium pace, then the cell remains intact. However, if it is a very rapid multiplication of the virus with a large number of viral particles, ultimately the cell is going to be destroyed. Clear up to this point? Any questions? HIV enters the bloodstream mostly through the genital or the colonic mucosa during sexual intercourse or other blood-to-blood contact, as we've already discussed. Once it enters the cell, once it enters the tissue, once it enters the blood or it enters the tissues, it is going to look for the cells which have the Cd4 and the chemokine receptors. And once the Cd4 chemokine receptor cell is been located, the GP120 and the GP41, they get attached to these receptors. The first cells which are targeted are usually the Langerhans cells, the tissue dendritic cells, and rarely we have the T cells. So the tissue cells, they are the most common, as we know that the sexual intercourse is the most common route of transmission. So the tissue dendritic cells and the Langerhans cells are the cells which are going to be affected most rapidly in the initial stages. HIV primarily is going to affect the CD4 positive T helper cells, CD4 positive cells of the CD4 positive T helper cells, and the inducer cells. Then we have the CD4 positive cells of the macrophage lineage, like this the monocytes, macrophages, as well as the dendritic cells present in the skin and the microglial cells in the CNS. So any cell in the body which has a CD4 marker, which has a CD4 receptor, will become a target for the HIV attachment. So coming to the process which is occurring within the body. Now this was one component of the pathogenesis, that is the entry of the cell into the body, and then what it does within the cells. And now what is going to be the next step for this virus to do? What it does is that it produces a primary infection when it is going to infect the dendritic cells or the T cells, CD4 positive T cells. So when they capture these, when this virus gets attached to their cell membrane, these viruses, they go into the cell, take over the DNA functioning of that cell, and start making their own a progeny. And these viruses then get drained, or they can get spread to the lymphoid tissue, and this results in an acute infection at this stage, because there are a large number of HIV infected cells in the body at that time. So the lymph nodes, the spleen, they can all become infected with the HIV at this stage, and this is then going to result in the release of a large number of viral particles into the bloodstream, and this is known as the viremic stage of the disease, and this is also known as the acute HIV syndrome. As a result of this viremia, this organism is going to spread into the various parts of the body. CD4 cells, because of the attachment of this virus, they are not going to release normal amounts of interleukins, interferons, and other lymphokines. So the immune status of the individual is not as good as that of a normal person. Therefore, the antibodies which are going to be produced, although they are going to be produced, they will not be in the same manner as in a normal individual. Also, there is the activation of the cytotoxic T lymphocytes. So, cytotoxic T cells will also become activated and they will start killing the HIV infected cells. This will result in partial control of the viral replication. Because of the cytotoxic T lymphocytes killing the infected cells, there will be a partial control of the viral infection, and this will result in the individual going into a chronic phase, which is also known as a latent phase. Latent phase, why? Because there are no apparent clinical signs and symptoms of the disease, or there may be a very low level of infection which does not produce any signs and symptoms. In the latent infection, what is happening is that within the cells, within these cytotoxic T lymphocytes and other T lymphocytes, memory T cells, this provirus goes and sits down. It does not multiply. It does not utilize the machinery to start producing a lot of viral progeny. In case of a low level infection, viral progeny is being produced, but in a latent infection, it is just sitting there dormant. It is not doing anything. So that is why it is known as a latent infection. It is hiding within that cell so that the immune system of the individual cannot destroy it, but at the same time, it is alive. It can become activated at any time due to any reason, whether it's a further decrease in the immune status of an individual, whether there is some other infection which causes a decrease in the immune status of an individual, or there can be some other trigger factor. This latent infection can become an extensive infection, and this would become an extensive infection because this virus becomes activated, it starts multiplying, and there is extensive replication of the virus. Both the latent infection and the low level of infection can pass into this phase. Once it goes into this phase, there is extensive replication of the virus, extensive lysis of the CD4 T lymphocyte, there is destruction of the lymphoid tissue, there is a decrease in the CD4 T cells, and this is known as the AIDS syndrome. So when you have extensive destruction of the CD4 T cells and certain other factors which are the pathognomonic of the AIDS, then we say that the patient has gone into the last stage of the disease, and that is referred to as AIDS. There is incomplete clearance of the HIV infected cells, and various signs and symptoms will become apparent in that individual at this stage. Now, receptor for the virus is the CD4 receptor. As we've already discussed a number of times, binding site is the glycoprotein 120, and virus gets integrated into the genome of the infected cells, and once it is there, it can either replicate rapidly, producing an infection in the initial stages, producing a viremia, or in the later stages, it can just cause a latent infection. It's sitting there, not multiplying, it's just hiding within the cell. And periodically this latent infection becomes activated and the virus starts multiplying, and it is going to release the progeny virions into the circulation, which are going to go and infect the other cells. The long and variable incubation period of the disease is because of this latency which the virus shows, and this is a characteristic feature of HIV infection and a few other viral infections. Primary pathogenic mechanism, as we've discussed, is the damage to the T lymphocytes, mainly the CD4 lymphocytes. When the CD4 lymphocytes are damaged, they are going to decrease in number, and the normal ratio of CD4 to CD8 is reversed. CD4 normally is present in a higher concentration, 500 to 1400 cells are present, as compared to the CD8, in which it is about I think half the number, and the normal ratio is 200, because the normal ratio is 200 between CD4 and CD8. In case of HIV, this is reversed. The CD8 number increases and the CD4 number decreases. Therefore, the immune state of a person also becomes low. Apart from the T cell mediated immunity, there is major damage. Sorry, the major damage is to the cellular immunity, but the humoral immunity is also affected. But the antigen are not very good antibody producers. The patients, they are unable to produce very good antibodies against these antigens, and there is polyclonal activation of the B lymphocytes. That is, all types of immunoglobulin classes are going to be activated, and there is going to be a hypergammaglobulinemia. So IgG, IgM, IgA, IgE, all of them, they are going to be produced, but the maximum amount is of the IgA and IgG. In case of infants, it is the IgM which is produced in maximum amount. But since there is polyclonal activation, these immunoglobulins, they really do not have a very protective effect in that individual. Monocytes, macrophages are also affected, as a result of which chemotaxis, antigen presentation, and intracellular killing is also affected. So as their normal function is not present, so all of these functions, they are also going to be diminished. And natural killer cells, they are also going to be affected by the HIV. As it is going to affect all of these cells, therefore the immunity of that individual is going to be depressed. So here is a picture which is going to show you that these are the HIV CD4 positive cells, which can be the CD4 T cell, CD8 positive cell, they can be the macrophages, they can be the B cells. And once you have the CD4 positive cell activated or destroyed, this is going to result in the decreased lymphokine production and loss of stimulus for T and B cell activation. CD8, it is going to result in impaired cytotoxic activity, impaired feedback, resulting in lymphopenia. The number of lymphocytes in the body are going to be decreased. CD4 CD8 ratio is going to be reversed, and there is decreased delayed hypersensitivity reactions. When the macrophages become affected, there is decreased chemotaxis and phagocytosis, decreased interleukin-1 production, and impaired antigen presentation, resulting in increased susceptibility to opportunistic infections and other infections. Then when the B cells become affected, there is decreased antibody production, and there is a hypergammaglobulinemia. So this non-specific increase in the immunoglobulins is ultimately going to result in increased susceptibility to opportunistic infections in the body. Similarly, lymphocytes, when the lymphocytes decrease in number, when there is a reversal of the CD4 and CD8 ratio and delayed hypersensitivity, again increased susceptibility to opportunistic and other infections is the end result. When we look at the serological profile of HIV infection, you see that during the acute phase of the disease, you will find the P24 antigen and the RNA detectable in the serum, and their concentration rises to a peak, and then as the acute phase subsides, so does the P24 and the RNA of that individual, and the individual then goes into the asymptomatic phase, in which the P24 vanishes and the RNA is going to be present in low levels. And when the symptomatic stage occurs, then again the RNA resurfaces along with the P24 antigen, and their levels are going to rise towards the end stage of the disease. The antigen to the P24 is going, as the P24 is going to decrease in amount, the antibodies against that are going to be rising, and during the asymptomatic phase they are going to be at the highest level, and then as the symptoms appear, again they are going to start decreasing. Then we have the antibodies against the envelopes. Again the same thing, during the acute phase they are going to rise, and they are going to then maintain a steady level throughout the disease course. CD4, during the initial stages, when there is an IV infection, there is a dip from the initial concentration, but as the acute phase passes, they may start increasing. But again, during there is a decrease as the patient goes into the asymptomatic phase, because the cells, they are being infected by the HIV virus. And although the dip does not become very drastic, but it maintains a steady level in the asymptomatic phase if the infection is low, or if the patient goes into the latent phase. But as the symptoms appear, so does the level of CD4 goes down. Three mechanisms by which the HIV is going to evade the immune system. Number one, it gets integrated into the host cell DNA, and it results in a persistent infection in that cell. And since it is within the host cell or within the nucleus of the host cell. Therefore, it cannot be reached by the various immune mechanisms of the body. Number two, there is a higher rate of mutation of the envelope gene. Since this is mutating at a very high rate, therefore any antibodies which the body produces against these antigens, they will not be effective after a short time period. So as the mutation rate is high, so the antibodies become ineffective as soon as a mutation has occurred. Then we have the TAT and the NEF proteins, and as I told you previously, they downregulate the class 1 MHC proteins, which are required for the cytotoxic T cells to recognize and kill the HIV infected cells. So since the cytotoxic T cells are not going to recognize the MHC class 1 proteins along with the antigen, so they are not going to kill those infected cells. So the infected cells can contain the virus, and the virus can remain within the cells for an interminable period of time, for a long period of time, without those cells being destroyed. There are different factors which cause immunodeficiency in a patient with HIV. Number one, direct cytopathic effect, as we've discussed. When it goes into the cell, some of the cells, depending upon the multiplication rate, will be destroyed. Some of the cells will be destroyed by the cytotoxic T lymphocytes. Then there can be chronic activation of the T cells, which ultimately is going to predispose these cells to apoptosis. When the whole machinery becomes exhausted, then the cell is going to go into the apoptotic phase. Then we have the cytotoxic T lymphocytes, which can kill all the CD4 positive T cells which are infected. This killing is going to reduce the CD4 count in an individual, and consequently an immunodeficiency will occur. Then the HIV infected CD4 positive T cells are also the target for the antibody dependent cell mediated cytotoxicity. So these can be killed by the antibody dependent mechanism as well. Then we have, because the CD4 cells are being depleted at a rapid rate, they are also being synthesized within the thymus, but they are going to be released into circulation because of the rapid requirement in an immature stage. So since they are defective, they are not going to be as effective in or they are not going to be as immunocompetent as the matured CD4 positive cells. Then there can be functional defects in the immune system, and this could be because of the decrease in the T cell response to the antigens. It could be decreased because of the poorer humoral immune response, and decrease basically in the number of the T lymphocytes in the body. Coming to the clinical manifestations of HIV and AIDS. HIV infection damages any system in the body, but most commonly it damages the respiratory system, the CNS, the GIT, and it is associated with certain malignancies. In the respiratory system, commonest infections include pneumonia, bronchitis, and pleuritis, or the infection of the pleura. It can cause the CNS infections like meningitis and dementia. In the GIT, it can cause diarrheas, it can cause a decreased body mass because body weight is lost, and it can cause inflammation of the intestines, and which ultimately are going to result in diarrhea. Caposi sarcoma is one malignancy which is very, very commonly associated with the HIV and AIDS, but other tumors can also occur. Four main stages of the infection. Number one is the incubation period of 2 to 4 weeks. Then there is a stage of primary manifestation, which can be a latent period of many, many months or many, many years. Then there can be a secondary stage of symptoms and signs of the disease, and then there is the terminal stage, which is referred to as AIDS. So first of all, the initial infection, which is also referred to as the acute retroviral syndrome, is has a duration of 2 to 6 weeks, but it can be up to 9 months. So 36 weeks, patient may remain asymptomatic, and this initial acute phase can persist. 50% of the patients may have symptoms of acute viral fever, like there can be a rash, there can be a joint pain, sore throat, diarrhea, lymph nodes, swelling, there can be a fever. During this phase, the HIV antibodies are not detectable. HIV antigens are not detectable. And this is referred to as the window period. This window period you are also probably studying in the hepatitis viruses. This is a period in which the Virus is present in the body, it is actively multiplying, the patient is infectious. But when you carry out the serological testing, you can neither find the antigen nor you can find the antibody. This is because the antigen and the antibodies both are in such low levels that they are not detectable. But despite that, the patient is highly infectious because the virus is present in the body and it is going to be present in the various secretions of the body. The second, after the acute symptomatic stage, the patient goes into the asymptomatic carrier stage, which is referred to as the clinical stage 1. And during the early asymptomatic stage, the CD4 count is normal. It is between 500 to 1400, and there are no signs and symptoms of any sort of a disease. The patient appears to be perfectly normal. However, with the passage of time, there is a progressive deterioration in the immune system of that individual, and although the patient remains asymptomatic and does not seek any treatment, this phase may last for as long as 5 to 7 years. The signs and symptoms of persistent generalized adenopathy, lymphadenopathy, may be present in such individuals over the course of the years. During the clinical stage 1 or the asymptomatic carrier stage, both antigens and antibodies are detectable, and during this period also the patient is highly infectious. Then we have the second stage, which is referred to as the AIDS related complex state. This is the intermediate phase of the HIV infection in which the CD4 count falls between 200 to 500. There are no opportunistic infections, but the patient presents with a series of different types of infections, like they can be recurrent oral ulcers, they can be a moderate weight loss, they can be sinusitis, pharyngitis, tonsillitis, or they can be a middle ear infection, otitis media. They can be skin infections like herpes zoster, seborrheic dermatitis, or pruritus, or the patient may present with ulmonary tuberculosis. But opportunistic infections are not present at this stage. Then the third stage is the late stage HIV disease or the AIDS state. In this, there are number of opportunistic infections. CD4 count falls even below, even lower, that is 50 to 200, and they are unexplained phenomena occurring in an individual for which nobody can find a reason. Intermittent persistent fever, night sweats, chronic diarrhea of more than 1 month duration, weight loss of more than 10% of the body weight, anemias, leukopenias, thrombocytopenia because of bone marrow depression, oral hairy leukoplakia. That's a white patch on the side of the tongue which has a sort of a hairy appearance. Then we have severe infections, pneumonias, meningitis. Patient can present with empyema, or they can be opportunistic infections like pneumocystis jirovecii pneumonia. They can be cerebral toxoplasmosis, which is a parasitic infection. They can be pulmonary or disseminated tuberculosis. The patient can present with cryptococcal meningitis or oropharyngeal candidiasis. All of these infections are very severe. Cryptococcal fungal infection, candidiasis again a fungal infection, tuberculosis, mycobacterium tuberculosis is the causative agent, cerebral toxoplasmosis because of a parasite, and this is again a bacteria. Pneumocystis is a bacteria. So we are going to have various types of opportunistic infections presented by the patient during the third stage of the disease, and here the clinical picture of AIDS becomes more apparent as compared to the previous stages. Then we have the fourth stage, which is the advanced state of HIV or the full-blown AIDS, and in this case we will see the various signs of HIV. Wasting syndrome, CD count less than 50. They can be neurological manifestations of motor abnormalities. They can be impairment in the cognitive behavior. They can be behavioral changes. They can be changes in the actual movement of the patient. They can be various types of malabsorptions. They can be wasting of the muscles. They can be extrapulmonary tuberculosis, that is TB, not in the lungs but in other organs of the body. They can be seeding of the tubercular bacilli in the various parts of the body known as miliary tuberculosis, or they can be mycobacterium avian immune complex infection, intracellular infection, that is the mycobacteria other than tuberculosis can also cause an infection in the HIV and AIDS, and avium intracellularum is the most common non-TB organism which is associated with the AIDS. Then there can be Caposi sarcoma or the CNS lymphomas. There can be fungal infections like histoplasmosis, esophageal candidiasis, candidiasis of the candida infection of the trachea, bronchi, lungs. There can be cryptosporidiosis. Again, this is a fungal infection. There can be cryptococcosis, cryptococcal infection throughout the body. There can be isosporiasis, again a fungal infection. Sorry, isosporiasis is a parasitic infection. You can see within this picture there are a number of infections which can occur almost in every organ of the body, and all of these opportunistic infections can occur in an individual with AIDS. A word about Kaposi sarcoma: it's an indolent, slow growing, multifocal, non-metastasizing, that is, it remains local, mucosal or cutaneous, metastasizing, mucosal or cutaneous tumor, probably of endothelial origin, represented in the form of purple spots in the skin. In the initial stages, it remains non-metastasizing, and then later on, it metastasizes to various other parts of the body. Coming to the lab diagnosis. The lab diagnosis, you have certain non-specific tests and certain specific tests. Non-specific tests include: number one is the total leukocyte count, which decreases. Lymphocyte count shows a lymphopenia, and this is less than 2000 per cubic millimeter. Normally, it is between above the leukocyte count is between 4000 to 11,000. Then you carry out the T cell subset assays. You have the absolute CD4 cell count, which is less than 200. The CD4 CD8 ratio is reversed, and when there is a decrease in the CD4 count, that is a hallmark for the presence of AIDS. Then when we carry out the platelet count, it shows a decrease. Immunoglobulin A and G levels, they are going to be raised. Cell mediated immunity can be detected by the skin test, and it is decreased. And then you carry out the lymph node biopsy, and you will see the various abnormalities in these lymph nodes. Specific tests include the demonstration of the HIV antigen, antibodies, nucleic acid, or the other components of the virus, or you can isolate the isolation of the virus through PCR, or the detection of the, not isolation, we should say detection of the virus through the PCR. When we carry out an HIV diagnostic protocol, we have an initial diagnostic approach in which we carry out two types of tests. Number one are the screening tests, and number two are the confirmatory tests. The screening tests can screen for the antigen and the antibodies. So a screening test will be effective only when we carry out both the detection of the antigen as well as the detection of the antibodies. The antigen test is going to detect the P24 antigen, and the antibodies are going to detect the antibodies against the P24. And a negative result for these two are going to essentially rule out the HIV infection, except for the window period. But these tests are, if they are carried out during the later stages of the disease when you are suspecting AIDS, then these tests are, if they are negative, then they rule out the HIV infection. Then number two are the antibody tests. Antibody tests are carried out with the help of the ELISA, or certain rapid tests can also be carried out. And ELISA is the standard method for detecting antibodies, but the rapid test, although it gives you a result within 20 minutes and it can be carried out in remote areas, this lacks specificity. Once you have done the screening test, then you need to confirm whether your screening tests are positive, whether the positive screening test is actually positive or not. So the number one test would be the HIV-2 antibody differentiation test. This is carried out through an immunoassay, which is going to be carried out with the help of an ELISA, or you can carry out various immunoassay kits can be utilized, and you will detect both HIV-1 and HIV-2 separately. Then this can be confirmed with the help of the Western blot test. Last of all, we have the detection of the viral RNA, and this detection of the viral RNA is carried out with the help of the PCR test, and it will detect the HIV infection earlier than the antigen antibody tests. But at present, we only have tests for the HIV-1. We do not have tests which are approved for HIV-2. The viral RNA detection or the PCR should be carried out if we are suspecting a neonatal HIV infection. We are suspecting we have patients which have indeterminate results. We have patients which are presenting before the seroconversion, that is during the screening period, sorry, during the window period. The window period when you have the acute phase of the disease, the patient's H antigens are absent, the patient's antibodies are absent, but you still suspect that the patient may be suffering from HIV. That is the time when you carry out the PCR for the for the HIV RNA. And then screening of blood donors, also you can carry out the viral RNA, which is a more specific test rather than the HIV antigen detection test in the blood for in the screening of the blood. Then certain tests are carried out for the post-treatment monitoring as well. For the post-treatment monitoring, we carry out the RNA load. Viral RNA load is an indicator of the antiretroviral therapy response. If this load decreases, that indicates that the treatment is effective, and it becomes a prognostic marker in the long-term treatment of this disease. Then we can also carry out the CD4 plus count, and this also tells us about the overall immune function. If the CD4 count is increasing, that means your therapy is effective, and this also is going to help us in treating the opportunistic infections, or you can give prophylactic treatment for the opportunistic infection so that the individual does not develop an opportunistic infection. But if the CD4 count is high, then you can carry out this prophylaxis. Then we can carry out the CD4 CD8 ratio, and this also helps in the evaluation of the immune status of an individual. Successful ART therapy means that the CD4 CD8 ratio is going to go back towards the normal, and if it is reversed, then it correlates with the immune dysfunction, and the viral reservoir is that the viral reservoir within the body is increasing. This is just a recap of everything which we've done. The key principles are that the HIV suppresses the immune function, resulting in impairment, destruction of the T cells, dendritic cells, and the macrophages, and we have the B cell dysfunction with hypergammaglobulinemia occurring as a result of that. The disease progresses from a primary to a chronic to an AIDS, a full-blown AIDS. The primary infection occurs through the breach of the mucosal tissues, resulting in a T cell HIV infects the mucosa, breaches this, goes into the deeper tissues where it gets attached to the CD4 cells, causes destruction. It also attaches to the dendritic cells. Dendritic cells go into the lymphoid tissues where the organism multiplies within the cells, resulting in a infection which is established within the body. And then we have the organisms going into the blood, resulting in a viremia, and thus with the help of this circulation, it is going to spread throughout the body. Then we have the development of the immune response in an individual as a result of this viremia, which is going to partially contain this infection. And we have the anti-HIV antibodies, and then we have the specific cytotoxic cells become activated. This stage is referred to as the acute retroviral syndrome. This is the first stage of the disease. Then the patient can go into a chronic infection in which the organisms become latent within the cells of the body, and they can be asymptomatic or they can be minor infections, but they can be a total absence of multiplication of the virus, or they can be a continuous replication resulting in the loss of the CD4 positive T cells. When the clinical latency passes into a rapid multiplication phase, then you develop the full-blown AIDS, where the opportunistic infections, neoplasms, and neurological diseases become manifested as the signs and symptoms of the disease. Therefore, in this condition, you will have a lot of immunosuppression and the depletion of the CD4 positive T cells. And over here you have the immune function impairment, that is the CD4 T cell depletion of the active and the memory cells. Cytokines favor the HIV infection because of their dysregulation. CD8 positive T cells have a decreased cytotoxicity, so they are not able to kill the viral infected cells. B cell activation results in hypergammaglobulinemia, but the immune response is not very effective, and there are a lot of lymphomas associated with the B cell activation. Macrophages are also not functioning properly, so there is reduced hemataxis, phagocytosis, and antigen presentation, all of which are going to contribute to the impaired immune function and the disease progression in an individual. So over a period of many years, this individual can start from an acute primary infection, go to the acute retroviral syndrome, then pass into the chronic latency phase, and then develop a lot of opportunistic infections and full-blown AIDS, and may ultimately, if not properly treated or if the treatment is not effective, can suffer and can succumb to the disease. Any questions? You can also put up your questions on the Facebook forum. We can I can answer any questions over there. Apart from this lecture, you are going to have now one or two lecture, I think one lecture left, or yes, one lecture left of Dr. Majid to complete the hepatitis, and then we will have finished with the virology, and your virology test is most probably expected during the end of this month. Probably, I'm not sure about the exact date, but it is expected at the end of this month. So if you have any questions before the test, start studying for the test. I know you have a neoplasia test before you will go for the virology test, but if you have any questions related to neoplasia, that forum is open for your answer, for your questions and answers. If you have any questions from immunology, from virology, all these questions, all this forum is open for your question and answers. You did not do very well in your SCQs in immunology, so please go through these topics again, ask questions so that you can understand the topic and attend these questions properly. Okay, thank you. See you next week.